Okay, good afternoon, everybody, and welcome to this afternoon's panel discussion on COVID-19 and risk. We're very grateful that you're able to join us, and I know we have people taking part on the panel from multiple countries and two continents. I don't have information on how many listeners we have and where you are, but whether it's the evening or the afternoon or the morning, you're all very welcome to join this discussion. I'm sorry that we've come online just a couple of minutes late. One of the panel discussion participants was having problems joining us, and we're just going to hope that that member can join us shortly. But in the meantime, I'm going to introduce to you the panel that we do have with us, and I'm going to begin by introducing and I'll do this in roughly in alphabetical order. Bert de Graaf, who is assistant professor in healthcare governance at the Erasmus University in Rotterdam, the Netherlands. Bert is trained as a sociologist originally at the University of Amsterdam, and along with some colleagues at Erasmus, he's recently authored an article in the journal Health, Risk and Society, which is entitled "Layering Risk Work Amidst an Emerging Crisis: An ethnographic study on the governance of COVID-19 pandemic in a university hospital in the Netherlands." And we'll be hearing more from Bert shortly. But before we go on to him, I'm going to introduce the other people who are with us on the panel today. The next two people I'm going to introduce, they're both authors from another recent article in Health, Risk and Society, and that article is called "From Risks to Catastrophes: How Chinese Newspapers Framed the Coronavirus Disease in 2019 in its Early Stages." And so these two colleagues joining us, first one I'll mention is Dr. Di Wang, who is an assistant professor at the Faculty of Humanities and Arts of Macau University of Science and Technology. And Di's research interests include health communication, communication psychology, and business communication. And Dee is going to present along with her co-author on this paper, Dr. Zhifei Mao, who is assistant professor in the School of Media and Communication at Shenzhen University. And Zhifei earlier in her career was a postdoctoral fellow at the Institute of Sociology at the University of Munich, working with none other than Ulrich Beck. And there's lots of very interesting Beckian themes in that article, which I look forward to hearing more about. And then next up we have Professor Michael Calnan, who's Professor of Medical Sociology at the University of Kent, and is currently writing a sociological analysis of the policy response to COVID-19. So again, a very strong connection to what we'll be coming on to discuss today. And that book is due to be published early next year by Emerald. And another reason why Mike's joining us today is that recently, along with Tom Douglas, Mike authored an editorial in Health, Risk and Society entitled "Hope's Hesitancy and the Risky Business of Vaccine Development." Welcome to everyone on the panel. And as I say, we're hoping very soon to be joined by Andy Alashevsky. Indeed, he's the author of the book, which we're kind of acknowledging today. Indeed, the taking place of this panel discussion is largely to launch the book and to think about key themes emerging in the book. And that book is COVID-19 and Risk: Policymaking in a Global Pandemic, which has recently been published by Policy Press. And so we're very much hoping to hear more from Andy on that. But in the meantime, I'll hand over, if it's okay, to Dr. Bert de Graaf, who will tell us a little bit of some of the key thoughts and ideas emerging from his recent work researching COVID-19 and risk. So Bert, over to you.
Thank you, Patrick, and also Patrick and Andy. Also, thank you for inviting me to share some of my research and findings in this panel. It's as was mentioned before, quite an honor, and I'm hoping also Andy will join us soon. Let me share my screen, and I will just briefly share some of the insights from the paper we published in Health, Risk and Society, mainly to bring it a little bit more to life. Of course, now I don't see you any longer, so bear with me. Patrick already announced the title of the paper, Layering Risk Work Amidst an Emerging Crisis. I'd like to acknowledge my co-authors here, Jens Bal and Roald Bal, who together with me did this research. It would be nice. It was actually March 2020 that that my professor had the idea that we should be following the pandemic as it emerged, and we were fortunate enough to be able to do so from the very start of the pandemic in the Netherlands by ethnographically and mainly through non-participant observations, following the decision-making process in one elite university hospital in the Netherlands from up close. If you look closely, you can see me here sitting. The bottom picture on the right, you see my curls there. This is the room with the board of directors there, and we followed this throughout the crisis, and actually we're still doing these ethnographies now in different modes, and we really notice how the pandemic changed the hospital inside and out. We focus on the question, especially how does the work in the hospital emerge as a sort of risk work throughout this crisis. And let me just quickly flag three of the sort of main modes of risk work we found. So how did they deal with the emerging pandemic in the university hospital? And one of the key aspects was working on numbers continuously and all the time. The people in the board of directors and generally in the crisis organization were working with numbers and numbering practices, mainly as a sort of a reductionist effort to manage and take charge in the flow of information and capacity management of the hospital itself. The second thing was working on expertise with all these huge amounts of uncertainties, especially microbiologists had to mobilize their own expertise and had to be able to translate their expertise about different risks and different uncertainties into several risk judgments, for instance, as conceptual, as made visible here in a flow chart such as this one, so that you see how risk is being translated to different contexts. And the third aspect of risk work, which we noticed, was working on logistics. Of course, personal protection equipment was very scarce, but also at one moment we started to distribute patients throughout the Netherlands to different hospitals. We were able to observe this process from up close. It's been a very fascinating one. But so the logistics of managing materials, but also people in different places, has been a very also layered exercise, as one of these pictures also shows. So what do I only got 3 minutes, so I'm quick here. So these are my conclusions. And so we concluding, we say that risk work was mainly aimed at dispelling and conquering risk and uncertainty. And so it was a very goal-oriented and top-down way of managing these risks. And you notice that especially healthcare professionals and the national government were in the lead here. So that makes us wonder a little bit, and that might be a good discussion for the panel as well. So what happened to this sort of more deliberative notions of risk governance, or more reflexive notions of risk governance during a crisis such as this? We also notice how the crisis or the emerging pandemic seemed to have washed away, perhaps temporarily, more ingrained institutional layers in the healthcare system. Generally, we have a quite competitive healthcare system in the Netherlands, and we've seen that especially in moments of high crisis, this sort of competitive thought or logics in the system sort of seem to have vanished for a moment. And so it's traditional institutional arrangement seems to have been strengthened. And we argue in the paper that we need more explicit organization of consultation and counter narratives to ensure a more balanced and reflexive approach to the pandemic. Well, that was it in a nutshell. Thank you for your attention. You're muted, Patrick.
Thank you for thank you very much, Berit, and thank you for covering so much in a short space of time and for sticking to that time. And as Berit touches upon, there's a very rich ethnographic analysis in that article focused on one particular hospital in the Netherlands, and now the next piece of research that's going to be discussed is kind of zooming out quite a bit, because we're thinking about media coverage, and particularly media coverage across the Chinese media. And so now I'm going to hand over to Dr. Di Wang and Dr. Zhifei Mao, who are going to tell us a little bit about their research. So over to you. Thank you.
Hello, everyone. I'm Zhifei, and it's our great pleasure to publish our article in the Journal of Health Risk in the Society. Our article is basically about the news framing of COVID-19 in China in its early stage. We focus on its early stage because we think like the first months after the Wuhan firstly reported COVID-19 cases was a critical stage for risk transformation. Risk refers to the imagination of a coming crisis or threat. So it highly depends on the media to kind of social construction of it. People can deny it, or people can recognize the seriousness of risk and kind of warn the public that a crisis or a catastrophe is coming and we should deal with that. But how to test it, how to know the media construction of risk. First, we borrowed the social theory of risk, especially Ersbeck's idea of the three characteristics of modern risk, which is first, delocalization, and the second, uncalculability, which means admitting the unknown of the impact of risk. That we admit that the risk is kind of, it surprises us again and again. And the third characteristic is the non-compensability, which means the realization that a risk is not compensable, and the recognition of which lies in the core of risk transformation, which means recognition of these three characteristics. We can kind of transform a risk into a coming crisis or catastrophe. And we kind of build up a bridge between the framing theory and the theory of risk society. We use media frames to test whether the media recognize these three characteristics or not. We use many frames there in our paper, but I think the two most important frames, the first is the consequences frame, and the second is treatment responsibility frame. People use by examining the consequences frame, we can know does certain risk, like does COVID-19 exist? It tells us whether a journalist admit the risk exists or not. And the second, how serious it is such risk predictable? Is it merely a local risk or not? By using consequences frame, we can test delocalization and uncalculability of risk. And then we move on to the treatment responsibility frame. This frame can tell us, is certain risk controllable? Is local treatment enough to deal with such risk? Because sometimes even if we admit a risk exists, the media can portray it as controllable with local treatment. And then people would not recognize the seriousness and the non-compensability of which. So this frame is also very important. Maybe I just let Dr. Wang to elaborate our findings and method. Thank you.
Okay, so for the method, we sampled two party newspaper and two market-oriented newspapers, and the sample time frame is 1 month, the first month after the outbreak. And there are 3 key dates during the first month. The first date is December the 31st, 2019, when the local authorities first admit that there's such a disease. And the second date is the Chinese version of Dr. Fauci, the head of high expert level of Chinese National Health Committee. He announced that there's person-to-person transmission of COVID-19. Before then, there's no such announcement and people don't care about it. And on January 23rd, 2020, as everybody knows, the borders of Wuhan were closed. The city was locked down. So we divided the first month into 3 time phases. And here's the description, and we don't have time for it. And we can see the number of coverage, of course, rose significantly by the end of the month. And the top, most frequently mentioned frame is the treatment responsibility frame, followed by consequences frame and human interest frame, etc. We also have the data in the tables, and we also break down each frame with themes. And you can see we highlighted the themes that occurred frequently in each frame. but for time limit and also about the sources. I will just report the discussion. So during the first phase, COVID-19 was portrayed as a local risk, that is enough remedies and limited impact. During the second phase, COVID-19 was portrayed as a Chinese risk. It has threatening consequences that required upgrading of remedies. And during the third phase, we can see it portrayed as a national and global catastrophe with multiple consequences and corporate solutions. So as we don't have much time, I'll briefly say that during the first phase, they only the main frames they use are treatment responsibility frame and consequences frame, and the sources they cited were most the local health community and the local government. And during the second phase, the most frequently used frames are consequences frame and treatment responsibility frame, and the source upgraded to national health community and central government of China. And during the third phase, the frames is multiplied, and also global experts' voice can be seen. So here's our conclusion. And the study confirmed that uncalculability, non-compensatability, and delocalization lie at the core of transforming insubstantial risk into upgrading catastrophe. Initially, Chinese journalists had a modernist perspective of risk. They believed that scientists can transform the risk into a probability and then control it. However, as time went by, the Chinese journalists and the Chinese society were repeatedly surprised by the virus, and they eventually had to admit the uncalculability, non-compensability, and the delocalization of the risk. And the major condition for risk transformation in China, we argue, is that the judgment on the threatening consequences of the virus was confirmed by the leading scientists in China and the Chinese central government. Okay, that's it. That's it for our presentation. Thank you.
Brilliant. Thank you very much, Dee, and thank you very much, Shufai, for a very interesting presentation, and again for squeezing so much into a short space of time. That was a great overview. I see now that Andy has joined us, which is brilliant. However, I'm not now seeing Mike, who I was about to give the word to. So hopefully Mike Cannell will rejoin us. Through the wonders of modern technology. But Andy, if you've caught your breath after grappling with all sorts of technological hitches for the past little while, we were just in the process of going around and asking people just to speak briefly to their, our colleagues' cases, papers, and obviously for you for the book. So did you want to just share with us for a few minutes just maybe some of the key things you wanted to highlight in relation to the book, please?
I suppose I very briefly wanted to sort of explain why I wrote the book in the first place. I was originally invited about 10 years ago to join SPI as an expert on risk. And it seemed fairly obvious when we were looking at the evidence that if you had a serious pandemic like the 1918-19 one, the only effective way of dealing with it was with some form of social distancing, reducing border crossings, etc. What was very interesting, though, was that, in fact, that was seemed to be an unacceptable message to the civil servants, because it involved impinging on civil liberties. So, in a sense, that's been I think it's quite a deeply ingrained perspective within sort of probably liberal democracy. So it's a serious problematic. Of course, more recently, the issues of, we were traveling to France to, my brother-in-law was ill. And as we traveled in February, we were watching the French lockdown, and apparently no similar reaction in England to the evidence that there was clearly very serious problems coming. So one of the questions I was addressing is why, in a sense, were we so slow in recognizing and reacting to that problem? And sort of lastly, in a sense, the issue of the science. The science has been extremely effective in some respects in the pandemic. If you compare, say, 1918, 1919, it took 80 years to sequence the genome of Spanish flu, it took equivalently about 8 weeks to do all the stuff that they took 80 years to do. So the science has been very effective. However, the social science has been rather lacking. Perhaps some psychology has been involved, for example, in risk communication. But beyond that, in a sense, social scientists, I think, have been fairly muted in their analysis. So looking at risk provides a way in, I think, for social science to contribute to an understanding of the pandemic. And as we're now talking about preventing future pandemics. That was my sort of introduction.
That's brilliant. Thank you very much, Andy. So in my haste, or partly my delight to actually see you joined, and in my haste to kind of keep things moving, I'd forgot to introduce you. So I'll slightly going back a little bit, but so as I've mentioned already at the start, obviously Andy is the author of this new emerging book, COVID-19 and Risk, and obviously this afternoon's discussion is partly very much to mark the emergence of this book and Andy's work on policymaking in a global pandemic. Andy is Emeritus Professor of Health Studies at the University of Kent, and before his retirement he was Director of the Centre for Health Service Studies, also at Kent. And another connection to health, risk and society, because obviously the discussions we've had so far are from articles published in that journal. Andy founded Health, Risk and Society and was editor of the journal for 20 years up until 2018. And there was more I was going to say, partly about your membership of that scientific advisory group. You've mentioned that yourself. And indeed, it's striking that you as a social scientist with a background more in kind of policy studies and anthropology and risk studies, that you were kind of invited at that point to be a member, whereas seemingly there's less of a diverse presence of social scientists, at least in some of the committees recently.
It's interesting the way that committee, in fact, has split into two, with one element being on the modelling side and the other on the behavioural side. And the modelling side has been the dominant voice in a way. Yeah. And the sort of social scientists are in the behavioural side, but that's really been a subsidiary. And the behavioural side is actually very heavily dominated by psychologists. Sure. So broader perspectives on risk seem to have got lost. I mean, the government talks about responding to the science, but they're very selective in the science they want to respond to. And in a sense, that broader critical perspective has somehow got lost in this pandemic.
Yeah, sure. Thank you very much, Andy. And I imagine that theme of the selectivity around science, I'm sure will become. I imagine we may well come back to you. Thank you. I'm hearing in my ear, I'm feeling a bit like a news anchor, that Mike Calnan's internet connection is down, unfortunately. So hopefully, if he gets back on, then we'll hear from Mike in a bit in relation to his recent work. But for the meantime, what I suggested to the colleagues once we'd heard from each of them was that each of us, and I'll maybe start myself to give the rest of you a little bit more time, just to respond to one idea or one particular interesting finding that we've touched on so far in the discussions. And so I'll be coming around to each of you, maybe to ask you to do that. Actually, Dee, did you want to come back? You wanted to come back?
Yes.
Yeah, that's great. Over to you. Yeah.
I actually prepared 2 questions, as I have read all 4 authors, including papers, and I found one common thing between Andy's book introduction, I only read the introduction, sorry, and Dr. Kelman, and also the paper Dr. Brown I cited before, is that the category of young versus old people in COVID-19. That is very interesting because during the early phase of Chinese outbreak, the Chinese media never talk about the older people, not never, but seldom, as we know, that talk about older people are more vulnerable to this disease. As one of the early whistleblower, a doctor who said there is a SARS-like disease, he died at 33 and in February. So he reported the first case, he was one of the first men who reported there's such a disease, and he died died 1 month later. So everybody in China mourned about him. And we know that young people could also die from this disease. However, as I read news from the Western media, it is consistently talk about how older adults are more vulnerable, and young people, they can just go out and will feel free to go out and go to a party, and they just worry about their grandparents may be infected. So I think this may downplay the risk of COVID-19 at the beginning. And I don't know how to test the result of this, but I found it's a common thing that the three authors both mentioned about this. And this is just one comment. Another thing is I found Dr. Kelman, who is not here, I read his paper and he cited one interesting number, that is 85 to 95% required for for herd immunity in a community, and he started to reach 2020. But according to the US President Joe Biden, he constantly say about 70% of the population to be vaccinated by July the 4th. And as he constantly mentioned this is kind of a framing effect. Everybody believes that 70% is a magic number. In fact, it's arbitrary. And now New York this week has just celebrated their freedom because they have vaccinated to 70% of their residents. So I think this is a really interesting framing effect. That is, according to scientists, you need about 85 to 95% people. But according to the mainstream framing, the president can say 70%, then everybody believes 70% is the magic number. Just my comment, and I don't know how we can empirically test this effect.
Thank you very much, Dee, for raising those issues. And actually, in some ways, it ties in because I was going to ask Bert maybe in a bit to reflect on this issue of framing, because that's obviously one of the core themes in the early part of Andy's book. And I was curious to hear. I mean, Andy talks obviously about framing in terms of the British government and how frames, once they're adopted, can hang around longer maybe than there's valid information for, in a way that undermines effective tackling of a problem. And I was wondering, Bert, whether you saw that also maybe at a more micro level at the hospital level. But maybe to return to your first issue you raised, Dr. Wang, which was this focus on age. And Andy, later in the book, you come back to age quite a bit, particularly in terms of the British government and their seeming oscillation between a focus on age and older people, and then moving away from that and moving back to it again. So do you want to maybe come in first of all and talk a bit more about age, please? Andy, were you going to come in? Could you?
Do you want me to?
Yeah, sorry if that wasn't clear. Yeah, could you come in first, and then I'll come back to Bert in a bit. But do you want to come in first on age?
I think the issue of categorization is interesting because it reflects on the nature of risk and how we construct risk. I mean, the reason that categorization was important in the UK in the first instance is because if you adopt the herd immunity approach, which came from the framing the new disease, COVID-19, like flu, you adopt herd immunity, there you need to define who is most vulnerable. And on clinical evidence, most vulnerable people are the elderly people. So the herd immunity forces you towards categorization. Once you develop the categories, the question is how you actually use those. And what I was suggesting in the book is that the categorization, which was to sort of give value and protection to the elderly, when the sort of first wave broke, it then became used for triaging and rationing resources. So the categorization is a process related to risk formation, but the values attached to the categories are those of the purposes of why you're using those particular categories. In a sense, you now look in Britain, and America, where vaccination has been given to the elderly as a priority to indicate the high value, whereas school children, in a sense, are last on the list, even though that if you're looking at intervening in the transmission, they should be higher up the list. So it's also difficult to get public debate about that. People are quite easy to talk about probability, but categorization of the values attached are ones which we find in democratic societies particularly difficult to talk about. Politicians deny, for example, that there was triaging in the first wave. Yeah, it never took place. Yet the evidence is very clear cut. It did take place. So that was sort of the reflection that we're gathering in the book on the categorization issue.
Great, thank you very much, Andy. And yeah, and again, the book picks up on that in lots of interesting ways, particularly how different categories are emphasized across different national contexts. And yeah, in the Dutch context, what I found striking, and Bert, maybe, yeah, you can maybe correct me on this, but gradually over time, the category of overweight became increasingly prominent, at least for a certain period of time, in the Dutch public sphere and political discussions. Whereas, in many other European countries, I didn't see that category of overweight and obesity stressed to the same degree. So again, it's interesting how some categories you see commonly across certain regions or globally, and other categories, emerge here, but and not elsewhere. Anyway, sorry, go on, Andy. Yeah.
I think the other category is ethnicity, the way in which it's very clear that there's evidence that the COVID impacts very differentially on particularly ethnic minorities, and how in the US ethnicity was defined as an at-risk category, whereas in the UK it wasn't. So you have the selectivity taking place, choices being made about which ones you prioritize.
And a lack of critical reflection on what are the values driving that. Thank you. Sorry, but having promised you the word, I've kept taking it away from you.
Give me the word. No, okay.
Over to you. And maybe you want to say something either more generally, but particularly maybe about what you saw happening at the local level in a specific hospital and how that was working. Thank you.
Well, thanks, Patrick. And I think there are many things I'd like to say. One thing, responding to your point about the magic number, we have also had a magic number in the Netherlands. I think that was the amount of intensive care beds we could manage, and we talked to the one who made up that number, because it was just a made up number. We were never really sure how many intensive care beds we had, and it just doubled it, like that might be what we need, and that became a sort of figure everybody was clinging on to. We need that many beds and then we will manage, but it was always some sort of made up number. So the impact and work of magic numbers in the framing of what the crisis might be and how we could effectively deal with it, I think is a fascinating topic for sure. And on the issue of categorization and framing, actually we have been mainly looking into healthcare system, crisis organization, that sort of level. And we noticed there that the issue of categorization is very important, but mainly in the sense of crisis making. At least that's sort of the link we make, is how is this sense of urgency and what to do when connected to especially the ideas of search capacity, personnel and materials. And we notice how these categorizations were first very simple, and they became more fine-grained as the crisis emerged, with in the end even the sort of the code black, the moment in which medical professionals can no longer facilitate and triage would be necessary, has become actually a very politicized issue in the Netherlands, very explicitly so actually, which I think is internationally quite a unique thing maybe. But that's, I think, a fascinating thing to follow. But on the framing, actually, we noticed that on the healthcare level, it was mainly focused on the intensive cares and making sure that the intensive care capacity would be maintained as effectively as possible. Of course, and that resulted in us counting beds all the time. Of course, as a sort of shorthand for the whole sort of social technical systems surrounding what an IC bed might mean. But that for sure has neglected for instance, the care for the elderly, which, as we said before, were perhaps the most vulnerable here. And so that sort of framing has had real effects in the way in which we distributed protective equipment, in which we focused in the media on what was being important. So we've seen many of these sort of framing effects, I think, are relevant. And I agree with Andy's observation that social scientists have been very, not involved in any sort of discussions on what to do. We saw that in the Netherlands, actually, our prime minister announced a couple of times on national media that he has no need for sociologists, which I think is a very peculiar thing to say. But I'm a sociologist, so I'm also a bit, so yeah, so that goes.
Brilliant. Thank you very much for those insights, Berit. Before we come back and hear again from other people on the panel, for other people who are watching and listening, just to let you know that at the bottom of your screen you should have a Q&A little button, and please feel free to use that and to pose questions. And you can either pose more general questions that any of us might have a go at answering, or obviously if you've got specific questions for specific people on the panel relating either to what they've said or to the research that they've been introducing, then feel free to do that. We've still got, I guess 20-25 minutes or so. We can probably run on a little bit more. So please feel free to post some questions. So we've been discussing, I guess, largely framing so far, and obviously there's things we can move on to, but were there any other kind of comments or thoughts in relation to framing that any of you wanted to share or come back to?
I think internationally there is an issue emerging, which is that in the initial framing that they're seen of COVID, there was the framing round in countries around the Asia Pacific rim, where they tended to frame it as SARS, Ebola, and go for a zero COVID policy, and quite effectively went for a zero COVID policy, where other countries went for a flu policy. Now, the problem is that those countries that went for a zero COVID policy now are faced with a world where COVID has been let out. And so what are those countries now going to do? In a sense, are they going to remain permanently with closed borders, or are they, they're slow in vaccination, etc. So in a sense, it's a world problem. And, given that you framed it in two different ways, how do you reconcile those two different frames?
Thank you, Andy. And I guess that latter issue, I guess, emphasizes more than anything, the pertinence of Ulrich Beck's work and his focus on, kind of globalizing and catastrophes, as doctors Wang and Mao obviously very usefully pick up on in their paper. Anyone else want to come back here? Berit first.
Yeah, well, maybe on the issue of globalization and framing, we noticed also very huge regional differences in the way in which the crisis was framed, in which the crisis was managed, especially on the healthcare system. So I was wondering, maybe, Andy, could you reflect a little bit about your observation on that sort of this regionalization, maybe also of these risks and uncertainties and how that's being dealt with?
I think there is the element of sort of a trust, a global trust, because the countries close to China, for example, if you look at Taiwan, the minute they heard that there was a pneumonia of unknown origins, they virtually monitored travels, etc. There was a basic distrust they had of information that they were receiving from China. So I think, possibly Vietnam, etc., etc. So it's a double experience of SARS plus a distrust of the official source of information. So I think there's that element. I think in Europe, the sort of optimism, I mean, the Trumpian optimism is a sort of interesting phenomena. It'll all be okay in due course, and how that could be sustained is a rather strange phenomena. the populist leaders, I think, in general, and the relationship between politics and populism and the pandemic, I think are quite interesting, and also the conspiracy theories. They've had rich ground in North America.
Sure. Thank you, Andy. Jifai or Dee, did you want to come back in here again? Coming back to framing and dominant frames, or some of the because I thought Jifai, you were about to add something, were you?
Yeah. I think basically, I think all the panelists, their topics are very interesting, and I'm mostly interested in when we talk about frames, because I think here only Dr. Wang and I are from the field of communication, but when we talk about frame, we kind of talk about like framing media, framing policies, framing in health policies. They can refer to different things, but I can see many similarities, which is very interesting. With regards to Andy's, of course, I think his book is very interesting. And if there's some time, I want him, because he talks about science. And I think the topic about science knowledge and COVID-19 is very interesting. And about social science and science, I think majority of social scientists, and I think majority of the scientists, when facing COVID-19, we can admit that this is not merely a health problem. It's of course a political problem. It's of course a social and cultural problem. So my question is actually Dr. Wang and I have co-authored another paper comparing the policies with regard to COVID-19 in 10 countries. And what we have found is that we can find a homogenization of those policies, regardless of the differences in political systems, cultures, and other differences. So we can see the homogenization of the policies across the national boundaries. So I'm very interested in Andy's book because apparently initially there could be many differences across the nations. But I want to ask Andy, do you think that the policies can be homogenized? So because Dr. Wang and I are surprised to know the findings. When we see the findings, we were very surprised, because those 10 countries, they are very different. However, eventually they took very similar policies like quarantine, and the policies just become so similar. So we don't know how to explain it. Maybe we can borrow some lights from Andy and other panelists. Thank you.
Thank you. Yeah, Andy, do you want to come back to that, particularly this interesting?
I think this is an interesting observation. I mean, you have to accept that there are sort of international cultures, for example, in science and medicine and communication. And one of the interesting phenomena is the speed at which sort of communication has taken place. There's also looking at international agencies like the World Health Organization, which in a sense provides a sort of a center for collecting and for disseminating practice. I think the World Health Organization suggestion is that probably at the early stages of the pandemic, there were strong differences. They refer to the lost month, February 2020 being a month in which, in a sense, information was beginning to come about the nature of the crisis, and action wasn't taking place in many countries. Obviously, since then, there's been a considerable more time to learn, A, about the virus, B, about the sorts of levels. And C, you've also had productions of PPE, etc., being brought, those things that we didn't have in terms of production have now developed. So I think time has been an important factor.
Great, thank you very much, Andy.
Can I make a follow? Yeah. And I think time. I think is a fascinating thing, always. But in regards to these health policy responses, then especially this whole idea of dealing with a crisis, we've noticed in our observations on this local level, right, Patrick, that we were focusing on, is that, for instance, generally the crisis organizations were focused on very short periods of time, so very short time frames, and the whole crisis organization in healthcare wasn't really prepared for this sort of long durée of the pandemic, and also the way in which the crisis then was also framed, and the waves of the virus with which you had to learn how to dance. Became quite of a struggle. So these sort of different logics of time and how that flowed into policy making and the practice that resulted from that, I think, is also a fascinating topic to and where we as social scientists, I think, can contribute as well.
Yeah, no, I think so. And I can imagine. Yeah, there's a very good book to be written on time framing and how that's shaped both, I guess, our ability to cope. Because if anyone had told us at the start how long this would go on for, I think we'd have found it much tougher in all sorts of ways. But then also how, as you say, but short-term time framing can also, will lead to very different responses.
I think one of the interesting issues was that in the UK, the reason to delay introducing lockdown was because of this concept that the population would become fatigued. In other words, there was a certain time limit that you could expect people to forego civil liberties. Well, it doesn't seem to be much evidence of fatigue. And it's difficult to know where it seems to have come from the nudge unit in the Cabinet Office.
David Halpin and these people.
Yes, yeah.
There's lots more we could say about time, for example, but I'm going to switch to a question we've got from the participants. This is from Dr. Kirsty Coxon. Thank you, Kirsty. I'll just read it out, and then again, people can chip in as they like. So Kirsty writes, the UK government has recently announced that vaccination will become mandatory for care home workers in England, but not for NHS staff, although there are similarly high levels of vaccine hesitancy amongst them. From the categorisation perspective, I'd be interested to know whether other countries are similarly switching between health workers as heroic versus health workers as risky. And I'd also be interested in any reflections of vaccine hesitancy in other countries, in health workers or the population more generally, and how this is being framed by governments or media. Okay, so does anyone want to respond to any of that? So either say this issue about encouraging or even compelling healthcare workers working in different settings to be vaccinated, or indeed kind of more broadly ways in which vaccine hesitancy is tackled or considered.
Yeah, I think Kirsty raises an interesting issue of the narratives relating to the pandemic. I mean, again, historically, we have considerable, we've had previous pandemics and previous narratives. And in England, it was interesting the extent to which the NHS did dominate the heroic narrative, but the sort of care homes, again, where the issue of staff spreading between homes became one of the media elements in it. So I'd be interested again on how that's constructed.
Thank you, Andy. Does anyone else want to come in here?
Yeah, I can say a little bit, maybe, though. I think, though, the question of vaccine hesitancy in the Netherlands, and maybe Patrick, correct me also if I'm wrong, I think you have a sense as well, as especially on the level of healthcare workers, not necessarily very much of an issue. I think the rates of vaccination are very high, and there's not much of public debate, although, of course, there are some people hesitant there. But this hero narrative has been very prominent here as well. I concur with Andy's observation, but it's very much focused, from my perspective, on the hospital setting, right? Those were the heroes at the intensive care departments, but people working in the elderly care homes are for instance, not taken into that sort of narrative for sure. So I think there's a very comparable view we had here in the Netherlands, and it became even more sort of pertinent when we had a huge shortage of nursing staff. I mean, I think that's also maybe a more global phenomenon, but especially that became apparent here, and they were demanding or asking for more pay, and they were denied such in the middle of the pandemic while we needed them the most. So that was also a very well, that didn't support the narrative of heroism so far, though.
Thank you. Yeah, I guess, yeah, one thing, one response to Kirsty's question, yeah, which relates, I guess, to how certainly in the media, people who are aware of being vaccinated, are discussed and framed. And I've got to be careful here, because it could well be just I'm accessing different types of media across different countries, but certainly in the American news media that I've come across, I think there's a more explicit discussion of vaccine hesitancy amongst certain minority ethnic groups, and potentially very good reasons for that hesitancy, given historic inequalities, historic ways in which science and medicine have treated some of those marginalized groups. Whereas indeed, I mean, a great academic take on that is work by Ruha Benjamin on kind of what she calls, rather than informed consent, informed dissent. Whereas I see less of a recognition of perhaps the good reasons for vaccine hesitancy in the Dutch media. I don't know if that's fair, but so there are certain groups in the Netherlands, including staunchly Protestant Christian Bible Belt, where there are high levels of vaccine hesitancy, and at least in the, again, it could just be the newspapers I've come across or the news sources I access, but I see less of a kind of portrayal in the media of emphasizing the reasonability and good reasons for that. That seemingly is less recognized. And again, I'd be curious to see what that looks like in other countries. Did anyone else want to come in? Yeah, Dee, thank you.
Actually, I was working with Dr. Mao about another paper about vaccination, and I read the vaccination hesitancy literature and found many predictors that the author that did not come today. But one thing that they did not mention that I observed is the outbreak of pandemic in a city can predict the significantly less vaccine hesitancy. I think this is just my hypothesis, because like 2 months ago, in many cities in China, they have to give incentives for people to get vaccinated. For instance, give cooking oil, give lots of other stuff. But now everybody wants to be vaccinated, especially in those cities that have outbreaks, like a few. But they stop giving vaccination for normal people. Only the medical staff can have priority, and those who have high vulnerability. So I think the outbreak before all the vaccinations maybe happen in a peaceful world. But now everywhere there's an outbreak, and then once there's an outbreak, people rush to get vaccinated. Just like in Taiwan, before the outbreak this year, people are hesitant to get vaccinated, although they don't have vaccination at the beginning. But even though they did have AZ vaccines, but they are hesitant. But now everybody get in queues and line for hours waiting for being vaccinated. So I think this is a good predictor of reducing. Of course, we don't like this predictor, but it is really significant to predict people. And also, I want to talk about vaccination hesitancy in China, because it's for children. The Chinese children don't have a choice. They are mandatory to get vaccinated. So the parents don't need to choose. If you need to go to primary school, you get vaccinated. So there's no such hesitancy for most children's vaccines. But for the COVID, they have a choice. So a lot of experts come to the media to advocate about it. That's my observation.
Very
Can I add maybe, Patrick?
Yeah.
I think this is interesting though, and these sort of predictors, and I'm noticing on the sort of notion of categorization and how do we conceive of people getting the shot or not, right? So how do they argue for it? Now in the Netherlands, the summer holidays are approaching. Of course, being vaccinated or not might depend on you being able to go on holiday, because borders might be closed for you if you're not vaccinated fully. So now people who are scrambling for vaccines are often just sort of said like, oh, you just want to go on a holiday. So this sort of different sorts of framing and categorizations are, I think, abound, but are not that present in and of itself. And I'd be actually curious, maybe on the level of vaccine hesitancy, if you could somehow maybe compare the vaccine hesitancy for the annual flu shots for healthcare workers, which I know are particularly low generally, or a high rate of hesitancy compared to the COVID acceptance levels. That would be, and the sort of the argumentation surrounding that would be interesting to delve deeper into, I think.
Very interesting. Thank you. It looks like Andy possibly has dropped out, and I've just seen a message saying Mike is still having problems with his internet. So they're both in Canterbury, so that's the common denominator, possibly just terrible internet connection in southeast England. I don't know, but anyway, yeah, I was hoping Andy was going to come back in, because I guess we've been touching on narratives, and there's some interesting work in the book about narratives, particularly the history of narratives, but also how certain narratives all of a sudden getting a huge amount of media attention, which in turn then shifts the framing. But the other thing I was going to ask him about was, and this is starting to look forward maybe to, the gradual institution of inquiries, and the likelihood that certainly in many countries, inquiries will take place to try and partly to try and learn lessons about what's been handled well and what hasn't been handled well. But also, as Andy emphasizes, also to apportion blame and kind of come to terms in a more cathartic way with the loss and the trauma, I guess you could say, of the last year and a half or so. This is probably where I'm going to stop, because I don't have the full awareness of the situation, but there's a short section in the book where Andy describes a fairly local inquiry that took place in and around Ischgl in Austria towards the middle and latter part of last year. And you'll remember that certainly in terms of the narratives about the transmission of COVID throughout Europe, certain Austrian ski resorts were highlighted, and Andy kind of unpacks this investigation into how things were done and how various different authorities acted to contain, or indeed seemingly to fail to contain the virus amongst tourists in and around this Austrian Valley. And again, I'd love to have invited Andy to say more about this, but I guess very briefly, the inquiry was deliberately set up in a more technical way. In other words, so explicitly it was said the role of the inquiry is not to blame anybody, but just to find out what happened. But of course, inevitably, as they've uncovered more and more of what happened, then explicitly or implicitly, blame is being apportioned in various ways in terms of various actions that were taken and various non-actions. So I don't know if I guess that's just some reflections of mine, and also I guess a way of highlighting some other interesting things going on in the book. I don't know if any of you want to come in here in relation to inquiries or the possibility of looking back with hindsight and what goes on there. Bert, you had your hand up.
Yeah, I can say something. Maybe you wanted to say something?
Actually, it's just I sent the link of the paper that Dr. Mao just mentioned about 10.
Oh, okay.
Oh, great. Okay.
If anyone is interested.
That's in the chat there.
Maybe I just want to mention, Patrick, that in the Netherlands, at least, I'm aware of that these sort of processes of inquiry are already going on, in the sense that research is being by the Onderzoeksraad voor de Veiligheid it's already going on behind the scenes. And I know that from the early days of the pandemic, especially boards of directors in hospitals were always prepared for what would come later when the blaming would start, right? So you noticed that, and that I found interesting, that this sort of anticipation of an inquiry already has an effect on the practices right now, and how that So what does that tell us about accountability and how these inquiries might work in and of itself? I think fascinating topic here.
Yeah, very interesting. Yeah, and I guess certainly in the UK, I mean, there have been in Parliament. I think it's the case in a few different countries. Also in New Zealand, there have been kind of select committees. So kind of parliamentary committees who call for evidence to investigate certain phenomena, and those have been very interesting in themselves. And indeed, although one thing I find both interesting and surprising and worrying is that evidence that was already established by those committees, say 6 months ago in the UK, has seemingly been forgotten about largely in the media coverage, and indeed the government are kind of making claims which directly contradict already the findings of those committees. So, for example, in the UK recently, in the last week or so, there's been a lot of coverage about the main health minister, who has claimed that there was never a shortage of PPE, personal protective equipment, whereas a parliamentary committee found seemingly pretty conclusively several months ago that there had been a shortage, and explored the reasons why. So again, coming back to time and how things develop over time, it's interesting that the findings at a certain point of time, although these inquiries are set up with the idea of learning from the past, things get forgotten very quickly, and surprisingly quickly, and in a rather worrying way.
Yeah, for sure. But I'd also be interested to follow up on how sort of the modeling of the crisis. But I think that's been a major issue in the Netherlands since the start of January. Modeling the reproduction numbers, modeling the ICU capacities, and then making policies on that. How that might influence or relate to these processes of accountability, because sometimes I get the feeling that if the model predicts it and then stuff doesn't happen, you're somehow always right, and it becomes a sort of circularity there with some feedback loops going on, which I think are worthy of investigation as well. So how does that work? What goes into the models, and how do these models work to help make policies and develop further on? I think it's another issue we can raise as social scientists.
I think so, yeah. And I guess, one thing to say there would be that obviously all models rely on assumptions. And when you've got a relatively narrow group who are similar in terms of maybe their scientific background, but also maybe their gender and class and so on, then if you've got a relatively homogenous group, then they're more and more likely to be blind to the assumptions that they're making, either in terms of policy making or particularly around modelling. Andy's rejoined us.
Yeah, sorry, I keep on sort of disappearing and then recoming. Yeah, I think the World Health Organization inquiries are quite interesting. I mean, firstly, the expert panel into the origins of the virus in China, and the sort of failure of that panel to sort of convince in some ways, with Biden sort of giving the intelligence service 90 days and giving, if you like, credibility to the lab theory again. So I think why the WHO expert panel didn't work more effectively is interesting. And secondly, the independent panel they set up also is an interesting phenomenon, because if an inquiry does two things: one, it investigates to find out what happened, but secondly, it allows some closure for those who suffered. How do you link the scale of the suffering to the findings of a panel? I don't think they could do it. All they could say is 3 million people have died. Well, that how do we then sort of come to account with that level of suffering? I think it's seriously problematic.
Yes, thank you, Andy. Andy, I don't know if you heard bits when you were gone. Obviously, you're aware that we're talking about inquiries. I did my best in a slightly ham-fisted way to tell people about the Ishgal inquiry,
Yes.
What happened in the Valley. And I mentioned obviously how, as you write about, the inquiry was set up supposedly not to cast blame, but obviously implicitly or explicitly ended up doing that nevertheless. Was there anything else you wanted to?
The Ischgl one's is a nice early one. I mean, there are two issues. Why you set up an inquiry? It's an admission of failure, in a sense, and an admission something is outside the normal. In the failure there is the media sort of blame a collusion between the local authority and the tourist industry with this evacuation that spread the virus through North Europe. So and the second thing is to sort of try and limit you're right, the blaming element of it. But without blame, actually, there's almost no point in inquiries. You know, the inquiry does actually blame, for example, the president in making his speech. So it's a very interesting mini example. But whether inquiries, for example, the UK inquiry will be used just to sort of kick the can down the road. How far do you have to kick the can down the road before it becomes a pointless exercise?
Yeah, thank you. And again, that notion of time and memory and loss and forget, those themes come back. With an eye on the time, I think it probably is my responsibility to kind of gradually round this off. So I guess if it's all right, what I might do is just go around the four of you, just for one fairly brief last remark, and that could be either relating to something that you've got out of today, or that it's led you to reflect on slightly differently, or it could be, as we've just been doing latterly, kind of starting to think forward and think, what's still to come, be that about inquiries, be that about the next few months and what they might look like, or it could be to do with, you might want to tell us a bit about your own research and thinking about this and where you're heading to next, and where you see there's questions that still need to be asked, or research that still needs to be done. So I've given you a bit of choice there, so hopefully not to put any of you too much on the spot. But yeah, does anyone want to kick us off with some last thoughts or closing comments?
Well, yeah, shall I kick the can as far as I can? Well, thank you, Patrick. Thank you, Andy, for inviting me and us and hosting this session. I think it's very nice to hear, to read your research first and to learn about your findings and to read your book, Andy, as well. And I think, well, we just touched upon lightly on so many, I think, important issues which we can contribute to, and I think also we should contribute to as social scientists. So I hope we can in the future to come. And maybe that's also, maybe that's the role of social scientists as well. Reflect maybe a little bit later, not in the heat of the moment, and bring about insights which might help us move further. We are still doing this ethnography it's still ongoing, actually, now more on the regional networks of care in the Netherlands. So we're hoping to bring some results by this summer, which are a bit more overarching than this one particular elite hospital. So I'm looking forward to getting that out as well. But one of the thoughts that triggered me is, and I see the paper by Dr. Mao here as well, and by that this the sort of cross-country comparisons of policy responses and framing issues. I think those are very worthwhile endeavors to look forward to as well. So thank you again for having me, and we'll see you around.
Yeah, thank you, Bert, and thank you for your contributions today. And indeed, we look forward to hearing more about those findings as they emerge in the next few months. Who wanted to go next? Jifai Mao, did you want to come back in? Yeah.
Sure, and it's a great pleasure to attend this panel. And I think the idea today every panelist has shared, I think they are very valuable, and it's quite eye-opening. I really agree with the panelists that the COVID-19 is apparently still ongoing crisis, and as a social scientist, we need to keep observing how it goes on. I think with regard to Orshbeck's theory, I think one possible concept we can test and analysis in the future study, and of course borrowing those eye-opening ideas of today's panelists, is like we want to know is can we create a kind of cosmopolitan community of risk fighting against this crisis? All the, sometimes the political leaders, they are just pointing fingers at each other, and we can see, we cannot see some united effort have made to fight against the crisis. So as a social scientist, I would like to keep observation of how situation goes on. And it's a great pleasure to attend today's webinar. Thank you, Patrick.
Great, thank you again, Xifai. And yeah, thank you for all that you've contributed. And indeed, yeah, of course, you're right. Yeah, this is still an ongoing thing, so there's still lots to discover, I'm sure. Dr. Dee Wang, did you want to close with some thoughts for us? Thank you.
Okay, so as Dr. Mao has summarized the insights from this panel discussion, I'd like to mention the vaccine study that we are conducting in the future. We're also thinking about health risk in society as our potential journal, as we want to know about the risk of vaccine, and it's different from other risks in terms of the benefit and risk, because taking a vaccine is risky because it can lead to side effects, and not taking a vaccine is also risky. You'll get the disease. So the two bad things, you have to wait which one is put more weight to you. So our future study would like to combine the risk theory with this specific issue, the vaccine issue, and see if we can just like this paper, combine the two theories together or find some bridge between them, and hopefully we will submit to this journal again. Okay, that's it.
Great, thank you very much, Dr. Wang, and yeah, thank you again for all your input today. And just a reminder, I mean, some of those themes you were touching on there, as you mentioned earlier on in the discussion, Mike Calnan, who sends his apologies, unfortunately his internet connection dropped, but he would have told us some interesting things about vaccine hesitancy, risk and trust. But although we can't hear from him on that today, several of our panelists, those articles and Mike's editorial in recent editions of Health, Risk and Society. And then, finally, I'll give the word to Andy just for some final comments from you, and then we'll close.
Well, my apologies for being a late arrival, and many thanks to Policy Press, A, for getting me online, and B, for hosting and organising this. And thank you very much, Patrick, also for chairing it. I think you've done a great job, given that people have been coming and going, and fighting with the technology is never easy. I mean, I do think COVID-19, from a social science perspective, has been fascinating. It's a bit like a solar eclipse. You can see things that normally you couldn't see. And illness and disease are sort of perennial human problems. Normally we deal with them individually and in modern society by ourselves. We've had to deal with them in the last year collectively, and the collective experience has been one, I think, that has tested people. And it'll be interesting to see how we emerge from this, and what will change and what will carry on, and whether we will live with COVID forever and a day, or whether we'll move on to something sort of different. So it's a fascinating thing, and I think risk is a rich vein, and hopefully we can carry on mining it. Thank you very much, Patrick.
Thank you, Andy, and thanks again for your contributions. Just a reminder that you're not only some of the work we discussed today available to read in Health, Risk and Society, but Andy's book is available from Policy Press. And indeed, if you look at the chat function, then you'll see some links, I think even with a discount involved, and it's an ebook, so it's fairly cheap anyway. So do have a look for that. And then finally, just to thank the people who've joined today, the participants. And obviously I touched just very briefly one of my comments around, and indeed a few of us have touched around COVID risk and its relationship to race and ethnicity. And Dr. Leona Vaughan from the University of Liverpool, she's put a comment in the bottom there with a link to some further work on that topic. So yeah, feel encouraged to check that out as well. I don't think I actually introduced myself at the beginning, but I'm Patrick Brown, and I'm from the University of Amsterdam. So yeah, just to fill that in. And I'm sure any of us today, I've introduced all the others, we'd be delighted to hear from any of you if you've got further thoughts or input. So feel free, I'm sure if you Google us, you can find us all pretty quickly to get in touch. But yeah, thank you for taking up your Friday afternoon to spend with us. And yeah, we look forward to this conversation gradually continuing in other media in the weeks and months to come. Okay, have a good weekend, and thanks again, everybody. Oh, and I'm sorry, just last, yeah, big thank you to Jessica Miles for your help, Jessica, this afternoon, and for helping us manage the technical issues. Thank you.
Thank you.
Okay, thanks everyone. Bye-bye.
Thank you.